We shall now go on to our last speaker, Dr. Sugato Paul, and again, a very amazing surgeon and the chairman scientific committee of OSWB, and also senior consultant, or rather director of Sunetra Family Eye Care Center, West Bengal. So he is going to show us a very challenging case which he has very well dealt. On to you, Dr. Sugato Paul.
Am I audible and is my screen visible there?
Yes.
So,
no, yes.
Yeah, so this is a straightforward case. I started with non-challenging case. And as I do my surgery, basically I nick the anterior capsule with the keratomy itself and put cohesive viscoelastic and go ahead and do the rhexis and proceed for phaco. And I did the same thing. It's under topical anesthesia, young patient. And I was introducing injecting the cohesive viscoelastic. And if you notice, it's going in fine. And suddenly it came out of the locker. I was using a liver leaf cannula, as you can see in the video. But in spite of that, it came out and injured. So what is the next step? So the first thing is to get a good view of the capsule, and I switched on the retroillumination, and this is what I can make out, that this is probably the extension. So in this situation, whether to convert or go ahead with phaco depends on the surgeon's expertise, grade of the nucleus, comorbidity, and also we have to decide the plane of the phaco. And if we are proceeding with phaco, few points we should remember, like minimal hydrodissection, then minimal lateral separation, then working away from the tear, doing a little bit of anterior planar phaco, maintaining the anterior chamber, look around for the wraparound sign as discussed by Rohit Omprakash sir. Sorry for the mistake in the spelling here. And look for the vitreous pull-ups, and if it doesn't work out, should always have a plan B. And in this situation, there shouldn't be any ego. Ego should be thrown away, and you should think about the patient's safety. And in this case, whatever you do, you need a good access to the nucleus. So need a good opening in the capsule, and I decided to proceed with the phaco. Because the tear was slightly oblique, slightly away, it was not exactly underneath the incision, I decided to keep the same incision for the phaco instead of transfer to a perpendicular place, and gave a nick with the venous scissor and did a hemirhexis on the side. I'm doing from sitting on the top up, and so I got a temporal rhexis here, and then I proceeded with the nick on the other side with the needle and completed the rhexis there. The other half of the rhexis. So you have to be very slow, but after listening to the experts like Rohit Omprakash sir, probably it will be better to do phaco with low parameters. And now, while rotating the nucleus, it is better to use two Sinski or two choppers so that you are not putting stress on the zonule. And during the phaco, again, minimum lateral separation. And if you can notice, I'm using the phaco tip and the chopper to rotate the nucleus so that no stress is put on the zonule. And again, while doing the chopper, the separation should be minimal. This is very important because the key point is not to put any stress on the zonule, or otherwise you might end up with wraparound tear or extension of the tear. So gentle chop into small pieces. I managed to get in this case. Otherwise, the option was to convert, but I was lucky on that day that I managed to get small chop. And once the chop was done, I managed to do the engulf all the emulsify all the small fragments. And all along, you have to keep an eye on the fluttering of the extension. And second thing is not to decompress your anterior chamber by taking away your phaco. Put viscoelastic so that the chamber is maintained. While doing the IA in this situation, transverse movement of the aspiration cannula helps, And then once you are sure you are not catching the capsule, get the cortex. Now the implant didn't go absolutely as my plan was. It's better to implant lens. It's not without rotating in the remaining portion of the bag, but in my case it was slightly off axis, but I managed to rotate it and then putting cardinal to get a round pupil and completed the case. Thank you very much.
Thank you very much. Can you hear me?
Yeah. Yes.
Yeah. There's some, I don't know, some electrical problem. The light's gone off, so I have not seen. But that was a wonderful video, Dr. Sugato. It's like keeping the best for the last. And there was, I mean, everything was so self-explanatory and every step of the way. But Dr. Rohit, I just wanted to ask you one question. In this kind of a case with the Rexix extension, would you like to chop all the pieces in the bag and then go on to remove pieces, or would you keep chopping piece by piece and then remove it? How would you want to do it in this kind of situation?
I think, first of all, we should congratulate Dr. Sugato for coming out with such an extraordinary display of surgery. Basically, the most important thing when you are doing all these things, as he was doing, you could see how he was chopping. You could see how his separational movements were.
Yeah.
The separational movements were in the direction of the tear. They were not perpendicular. Because if they are perpendicular, it has to be, you know, the direction of the separation is also very important. And the amount of separation you bring in, that is also very important. And once you separate, you can just, you know, emulsify it by bringing it in the supra, you know, capsular area. That is another important thing. The bottle height has also to be, you know, very well. It could have been better had you reduced the bottle height, because the low IOP pressure also helps in these situations. The direction of the, you know, has to be in the direction which has it to be perpendicular, or has it to be in the same plane? That is the most important thing. It has to be in the, it has to be 90 degrees from the area in which the axis of the you know, extension of the tear is. So that is also very important thing. And when you are using this phacoemulsification, one more important factor which has to be borne in mind is the site of incision preferably should not be in the line of the anterior capsular tear. If you can make it at some angle, maybe 90 degree, that would also be putting less stress on the anterior capsular tear which is there. So the question is, we should, if we have to do, we should try to not put more pressure. So by reducing the height, reducing the separational forces, number two, direction is also very important. And you should try to do the emulsification supracapsularly. And when you're trying to rotate, try not to rotate much, because if you will be rotating much, that also puts stress on the anterior capsular tear which has extended, which can make it a wraparound tear.
Yes, excellent. All the points very well brought out. Dr. Ramurthy, Dr. Gaurav, anything? This was the last video, so we would be concluding after any.
Just as an add-on to what Rohit was saying, you know, it's extremely important that the forces you apply for separation should be at 90 degrees to the direction of the runoff, and you do not want to stress in the direction of the runoff. And sometimes when you're doing a direct chopping, it's a little more difficult to control that. So sometimes what I prefer doing in these situations is to just go ahead and do a stop and chop technique, create a central crater. And especially this was not a very hard cataract. You hardly need any phaco energy, use low parameters, and rotate the nucleus at 90 degrees to the axis. For example, it's he had to chop obviously at the 3 o'clock meridian, but here I would rotate it so that my nucleus is directing from 6 o'clock to 12 o'clock, and make a very deep crater, and introduce two Sinskey hooks and just gently separate it so that I have two heminuclei. And then the soft nucleus, I would prolapse them into the anterior chamber, and we usually do just a phaco aspiration of this lens matter. So stressing the capsule to the minimal extent. And this also helps, but obviously the case was very well dealt with. But sometimes when this rexus runoff is there, then I like to do a stop and chop technique where the direction of the separation of the heminucleus is at 90 degrees, and I get a better control that way.
Hydrodissection should also be, you should try not to make a vigorous hydrodissection. And the placement of the IOL in such situations should not be in the line. The haptics should not be in the line. While you are introducing, you should, the moment it goes in the bag, it should be, placed in such a way that it doesn't go in the axis, because that also at times, puts pressure, and that can also make it a wraparound. Ideally, if you can make it 90 degree to the axis of the tear, that makes it less traumatic to the probability of the flap extending and becoming a wraparound tear.
Can I ask two quick questions, please, for my improvement?
Yes.
One is, basically my incision was at 12 o'clock. My extension was from 2 o'clock to 8 o'clock-ish. So would you suggest to give a fresh incision so that I'm perpendicular from the extension?
Ideally, yes.
Okay.
Ideally, yes.
And second thing, would it have helped if I had put I was lucky, but probably would it have been better if I had put the IOL on the iris, positioned it, and then nudged it inside the bag, probably?
Absolutely correct.
Yeah.
And
regarding one, sorry, yeah.
Go ahead. I mean, the way to ensure that you are at positioning is at 90 degrees, the intraocular lens, the optic haptic junction should ideally be at 90 degrees to the direction of the rexus extension. Because the haptics is almost all around. So you can't say that the haptics will not be there in the direction of the extension. But what we mean is that the optic haptic junction should be exactly opposite to the direction of the rexus runoff.
The curve of the haptic, the maximum curve where it goes to the equator, that should be at the axis. That should not be in the same axis. Because
practically speaking, to answer your question, Dr. Sugato, I don't think, I have never done this, at least, I mean, just because the rexus runoff making a separate incision, theoretically it might sound right, but practically I don't think most of us do that. And maybe the take home from this entire excellent presentation and the discussion is that we do not want to create any stress along the direction of the rexus runoff.
Yes.
I just wanted to add what Dr. Chitra had actually asked, that whether you would like to crack it completely into pieces and then do it, or so. I think what Dr. Ramamurthy sir said was that stop and chop would be a great way to go, but also the other way could be that if you're able to chop it easily, then remove one small fragment, like one small pie, and then you have enough space, and then crack all the others, and that ensures that your lateral forces of separation are minimized because you've debulked the nucleus by at least 1/8 or 1/6 or whatever. So removing that small one pie is sometimes good, and then you can go on to chop the rest of the nucleus and then remove it.
Yes. So that was wonderful, Dr. Sugato, and I think
one can do cross chopping also in such patients, because when you're doing cross chopping, you don't need to rotate. So ideally, if you can avoid rotating much, that is the best situation. And when you are trying to rotate, you should not go beyond the tear, because if you go beyond the tear, that can also create a situation where it can become a wraparound tear. So cross chopping here, as we have learned in the posterior polar cataracts, wherein we don't rotate and we do the cross chopping, and that can also help in these patients, where you can avoid the concept of rotating it more. So minimal rotation, minimal separational movements, and as Dr. Gaurav added, this is also a nice thing. You take out one pie and then try to, and as Dr. Ramamurthy also said, separational forces, just pull it. Since it was a soft one, you could have pulled it, made it supracapsular, and completed the procedure.
Yeah. So thank you very much. And I think I'm sure all of us do feel that with the cluster of videos which we saw in the last 3 hours, it's been such a wide variety of cases which got discussed. And and everybody put their life and soul into the talk. So thank you so much to my expert panel, Dr. Rohit, Dr. Ramamurthy, Dr. Gaurav, Dr. Rajesh, for being there, and amazing set of speakers. All of you, I'm not going to take individual names, but each video of yours was one to beat the other, and so much of learning, and it was definitely gave a lot of energy to this Sunday afternoon. I need to thank Harshul, who was to be my co-moderator, but was there for the earlier part. I need to thank my ARC team for always being there in the background to be supportive and help. And I need to thank Mr. Kripal and the entire AIOS team for all those SMSs which come to you, Sai and all the team of Numerotech, who ensured that these emails keep bombarding you along with my WhatsApp messages. I know, I actually imagine Gaurav shuddering when I start sending my WhatsApp. He knows going to shoot a number of them. And I actually smile at that moment, but I think that's the energy which ARC gives. Thank you very much, Dr. Anand Sethi and your entire team for being so supportive, last minute taking care. There was no glitch at all in sharing of the videos. Thank you so much for all of it. And finally, thanks a lot to all my dear watched it. And I'm sure some of you have missed some of it, can watch it later, because all of these are going to be loaded on the ARC website. Thank you very much. Thank you.